The eyebrow is really attached to the skin is attached to the muscle, and the traditional Browlift techniques, you have these planes. Again, you have the skin, which is attached to the muscle, and of course the brow is a part of the skin, and then you have your periosteum and gallia, if you're over the temporal muscle, and you've got the bone or the deep temporal fascia, again, if you're over the muscle. So the traditional brow lifts, you will go deep to the gallia, you will cut it down, and if you wait some time, that plane is very slippery, we all know that, the periosteum with the bone and the gallia with the deep temporal fascia is very slippery. In fact, you all know that David Nice actually advocates to remove some of that deep temporal fascia so that it sticks there laterally. But what happens with time is that it just all comes down, it's heavy, and we all know that we've had cases where just the eyebrow comes down. So I think in order to improve this, we have to think as the brow being part really of the skin. It's really part of the skin. So what other part of the body is a part of the skin and we are, as plastic surgeons, continuously trying to raise? Well, I think it's a good analogy. So again, this is the technique. I just will raise the skin. The skin will stick to the muscle. Of course, I can't go underneath the muscle directly because that's where the frontal branch goes. So you either have to go either subgaleal or subcutaneous. And this is just a short little video. I used the, actually he's from Montreal, the cameraman, you all know, technique to go tangent show to the hair follicles. There I incise I expose the deep temporal fascia. I'm going superficial to the muscle. The patient is wide awake. I have just nothing on her. This is a very good area, and it's very resistant. There's also papers on the subcutaneous Browlift. It's very resistant to necrosis or anything, and I do that. So now, when I do a couple of key stitches, I go with a PDS 3.0 round needle, non-cutting, and I take a nice bite, and I go directly above the eyebrow. And then I fix it to the deep temporal fascia, which we all know that it's a very firm, you can move and lift the head up just with that fixation. And then I place a couple of stitches, another one a little bit further down. Sometimes I even place a third one. And I can get a very, again, nice strong bite that you can move the head with that bite there. And just leave it with enough tightness so that, you get the skin to just overlap without tension, and then of course I remove that, and again I close with a 7.0 to make sure that I've got good scars. So I'm going to go skip over with this other technique I'm working on, auto-augmentation upper blepharoplasty. Now, we all know upper eyelids is a main part of our practice. It's one of the most demanded cosmetic procedures, and many times they turn out very simple, well, and come out